So on behalf of myself, I'm Bert Kosiski, president of cureCADASIL, and the former president is also on. That's Jane Gunther, and also Vinita Ball, who is a volunteer and helped set up this webinar. We welcome you to the CADASIL Connection webinar series. We're fortunate to have as a guest tonight, José Biller, who's the chair of the Department of Neurology at Loyola University. cureCADASIL is a nonprofit organization dedicated to helping patients, families, caregivers, and other supporters touched by CADASIL. We aim to unite patients and the medical community toward the common goal of treatments and ultimately a cure for this rare genetic disease by promoting communication, advocacy, research, and education. So our speaker tonight, José Biller, is a professor of neurology and neurological surgery, chair of the Department of Neurology at Loyola University Chicago Stritch School of Medicine. He is a former editor of the Journal of Stroke and Cerebral Vascular Diseases. He's published more than 380 peer-reviewed articles and 155 book chapters. He earned his medical degree from the University of the Republic in Montevideo, Uruguay, and postgraduate training in internal medicine. He completed residency in neurology at Loyola University and a cerebral vascular research fellowship at Wake Forest. He is a recipient, believe me, of numerous awards for teaching and clinical excellence. So Dr. Biller will discuss the need for natural history studies and how such studies provide valuable information for designing and conducting clinical trials when promising therapies become available. He is co-investigator in the National Institutes of Health CADASIL Consortium study, and he will tell us more about CADASIL, this study, its purpose and progress to date, what it entails, and who might want to participate. By way of housekeeping, please note that everyone in the audience will be muted during the presentation, but we will take questions at the end. So if you have a question, you can type it in the question box in the drop-down menu that you should be able to see on the right side of your screen. So without further ado, I'm going to turn this over to Dr. Biller.
Can you see my screen?
Thanks.
Very good. Well, thank you very much for the kind introduction, and thank you for all of those who are attending this webinar. Today's presentation is going to be a conversation on CADASIL, the most common single gene hereditary small vessel cerebral disease caused by a mutation of the Notch3 gene on chromosome 19. And at the end, highlights of the multi-center observational study of the natural history of CADASIL by the CADASIL Consortium. I have no financial disclosures. And as we all know, although the topic is not going to cover all genetic disorders pertaining to stroke, everyone understands that strokes is a complex genetic disorder with a heterogeneous phenotype. And when we are talking about small vessel cerebral disease, we like to look at certain biomarkers, and in this slide, I am highlighting 3 conventional MRI markers of small vessel disease. On the far left, periventricular confluent white matter hyperintensities. On the middle, a number of lacunar strokes, particularly affecting deep structures, in this case, obviously bilateral thalami. And on the far right, the presence of cerebral microbleeds that may organize in a cortical subcortical predominance, as we see when they reflect underlying cerebral amyloid angiopathy, or subcortical structures when cases reflect a hypertensive microangiopathy. The list of monogenic single gene disorders causing small vessel disease, ischemic in nature, continues to expand. So please understand that this particular slide is incomplete and is incomplete on purpose. CADASIL, that is the topic of today's discussion, is inherited as an autosomal dominant condition and is associated with the NOTCH3 gene. There is a recessive form known as CADASIL that is associated with the HTRA1 gene. And recently, when discussing leukovasculopathies, the introduction of the term CADASIL2, inherited in an autosomal dominant fashion, but related to the HTRA1 gene with a phenotype that resembles CADASIL, have been described. And there are other conditions like HERNS, HCRV, HANAC, CADASAL, and many others. Today, we are going to focus on CADASIL and highlight practical information, clinical information, and hopefully we can have an understanding about the challenges and the research for the future. The term CADASIL clearly is, relatively speaking, a novel term. But if we go back to history, as we should always do, more than 70 years ago, the famous Belgian neurologist Van Bogaert in 1955 describes a condition that for all purposes would correspond to CADASIL. And he labeled this condition as a subcortical encephalopathy of Binswanger type of rapid course. Other terms used in the 50s and 60s included hereditary multi-infarct dementia, chronic familial vascular encephalopathy, or familial subcortical dementia. The prevalence of CADASIL is estimated to be between 2 to 5 per 100,000. As I mentioned, is an adult, typically adult onset, autosomal dominant, hereditary small artery disease of the brain. This is a non-atherosclerotic, non-amyloid, non-inflammatory angiopathy due to a mutation of the NOTCH3 gene on the long arm of chromosome 19. And this NOTCH3 gene contains 33 exons. There are more than 200 NOTCH3 variants, and most of them have been identified in a cluster of exons, mainly 4, 3, 5, and 8, with less frequent mutations localized to exons 2, 6, 11, and 18. The mutations include missense mutations, small in frames deletions, and splice site mutations. So once again, CADASIL is the most common by far Mendelian form of small vessel disease leading to a hereditary subcortical dementia with insidious onset, with a mean age of onset in the 4th decade of life, although it has been recognized in younger people and has been described in all continents, and there is, without any doubt, in the last few decades, increased medical recognition. The Notch3 protein is critical for the vascular smooth muscle cell differentiation and vascular development, and it lends structural stability to the vascular smooth muscle cell. The cardinal clinical manifestations include migraine with aura in about 20 to 40% of patients, recurrent subcortical ischemic strokes, mood disturbances, cognitive impairment or dementia, and a variety of miscellaneous manifestations. Some unusual, but we will discuss them because they have important relevance when we talk about the phenotype of this disorder. Migraine with aura tends to occur earlier in women than in men. Men present more commonly with strokes than with migraine, and as I said, women present more common with migraines. When we talk about strokes or transient ischemic attacks in patients with CADASIL, obviously we are talking about small subcortical strokes leading to lacunar infarcts with a characteristic presentation of the better known lacunar syndromes, such as the pure motor hemiparesis, the pure sensory stroke, the sensory motor stroke, the ataxic hemiparesis, the clumsy hand dysarthria, and additional lacunar syndromes, more than 20 as described by C. Miller-Fisher. If most of the strokes are without any doubt ischemic in nature, parenchymal brain hemorrhages are described, but they are extremely uncommon. And they tend to correlate with the presence of microbleeds and hypertension. And that is very important when we talk about management strategies. So remember that the parenchymal brain hemorrhages are associated with the presence of microbleeds and the presence of hypertension. Mood disturbances include depression, apathy, or even manic episodes. Cognitive impairment, vascular cognitive impairment evolving to vascular dementia, is often associated with corticospinal tract signs, upper motor neuron features, leading to pseudovalvar palsy or pseudovalvar features, gait impairment with short, shuffling nature, and or urinary incontinence. Seizures are rare, have been described between 6 to 10%. They are more common generalized tonic-clonic seizures. They may be focal in nature, and they seldom evolve to status epilepticus. And the same is true for migraine. Seldom these patients have status migrainosus. So as I mentioned before, women more likely to present with migraine with aura. There are no distinctive features for the auras seen with CADASIL compared to those in patients without CADASIL. They are typically visual auras, and men are more likely to present with subcortical strokes rather than with migraine. And this evolution of the classical symptoms have been well captured by this seminal paper by Chabriat and collaborators in France, published about 16, 15, or 14 years ago. You can see that the earliest manifestations include migraine with aura. Very soon, there is the presence of the MRI characteristic abnormality in the white matter on T2 images, followed by subcortical ischemic strokes, mood disturbances, apathy, motor disability, and executive dysfunction characteristic of the dementia seen in CADASIL. This is a paper from Ditchgans and collaborators published at the end of in 1998. And you can see again that the initial feature, the clinical manifestations, the initial feature were ischemic deficit and migraine, almost in the same percentage.
100 people. I know. Oh, I started this.
I am having a background conversation, so please mute your microphones.
Knowing pharma is interested, I can direct them.
There are other manifestations. There are other manifestations.
Thanks for letting me not do it to No.
There are other manifestations that include CADASIL coma that I will briefly mention. We discussed about lobar hemorrhages and retinal abnormalities, but these retinal abnormalities are not associated with branch retinal artery occlusion or central retinal artery occlusion or a central or a branch retinal vein infarction or an ischemic optic neuropathy. But there are some retinal abnormalities that is important to understand as we describe phenotypes and the differential diagnosis. There are also some unusual, very unusual features. One is deafness. Remember that the differential diagnosis in these patients may include conditions that may be associated with deafness, like Susak syndrome, or, for example, a mitochondrial disease. So it is important then to think that deafness has been reported, albeit rarely, in CADASIL. Cranial nerve palsies may occur as well. Very seldom, spinal cord involvement with a myelopathy has been reported. Actually, one of my patients has an underlying myelopathy in addition to CADASIL. And then they are rare muscular manifestations. We all recognize some of the typical features on magnetic resonance imaging, the typical MRI abnormalities that include a diffuse leukoencephalopathy with T2 hyperintensities in the bilateral temporal lobes, mainly in the poles of the temporal lobes and external capsules, the presence of multiple lacunar infarcts, and as I mentioned, the microbleeds. So whenever you see the MRI, pay attention to the T2 weighted and the FLAIR images. You will see the involvement of the periventricular white matter, the centrum semiovale, the thalamus, the basal ganglia, the characteristic symmetric involvement of the anterior poles of the temporal lobe, the very unique characteristic involvement of the external and extreme capsule, the involvement of the brainstem involving the central pons more so than the midbrain or medulla, and involvement of the corpus callosum. Another characteristic that one will have to consider when discussing the differential diagnosis, for example, with multiple sclerosis or Susak syndrome. The infarctions are subcortical. In other words, typically there are no cortical infarcts. Another characteristic feature on MRI is the widening of the Virchow-Robin spaces. In about a third to two-thirds of patients, one will encounter microbleeds, and it's critical to know that some of these abnormalities may be observed in the pre-symptomatic phase. So here is an example of an MRI of one of my patients with a characteristic symmetric involvement of the anterior aspect of the temporal lobes, the temporal poles, and please note the involvement also of the external and extreme capsule. What is the differential diagnosis? One of the most common misdiagnoses is with multiple sclerosis. The coexistence of CADASIL and MS is extremely rare. The characteristic features on MRI previously described are not seen typically with multiple sclerosis. But there are other characteristic features that I will highlight in the next slide, helping in the differentiation of CADASIL and MS. But I want to mention other conditions that are commonly part of the differential diagnosis, one of which is Binswanger's disease. Remember the early description of Van Bogart. Cerebral amyloid angiopathy, obviously the distribution of the microbleeds will be important in that distinction. Some mitochondrial diseases like mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes, MILAS, a mitochondrial disease. CADASIL, the cerebral autosomal recessive arteriopathy with subcortical infarcts, and leukoencephalopathy. In Japan, this is known as Maeda disease. The patients are typically coming from families where there is considerable consanguinity. They typically have alopecia and lumbar spondylosis. I mentioned the CADASIL2 with a phenotype like CADASIL associated with the HTRA1 but autosomal dominant. We mentioned MS. Cerebral vasculitis is important in the differential diagnosis. Certain leukodystrophies, for example, adrenoleukodystrophy or metachromatic leukodystrophy, or other leukoencephalopathies of unknown cause. A recent article from China published in Brain refers to a category of adult genetic leukoencephalopathies as leukovasculopathies. And do not forget, because of the cognitive impairment, the differential diagnosis with other dementing illnesses such as Alzheimer's disease. This is a very simplified diagram to help the clinician with a path to differentiate CADASIL from MS. Strong family history in CADASIL, migraine, typically migraine with aura, the characteristic involvement of the temporal poles and external capsule that is not seen in MS, the presence of symmetrical abnormalities and widespread abnormalities typical of CADASIL Conversely, myelopathic involvement, particularly in the cervical cord, will be more commonly seen with MS than with CADASIL. How do we diagnose CADASIL? Typically, with genetic testing, and you can see that genetic testing has a very high sensitivity and specificity, and the same is true for immunohistochemistry of skin biopsy, looking for the characteristic granular osmophilic material deposits in the tunica media of vessels that is considered almost, I wouldn't say always, almost pathognomonic. Please understand that the electron microscopy of skin biopsy has a sensitivity on only 57% with a specificity of 100%. I am not going to dwell too much in therapy. I'll be happy to entertain any questions in the chat or subsequently, but giving you an overview with a lots of caveats. Number one, as yet, as of today, there is no proven therapy to influence the natural evolution of CADASIL. Because these are patients at risk of recurrent ischemic strokes, it is typical that these patients are receiving antiplatelet agents, cholesterol lowering agents, and blood pressure medications. A common question is asked whether or not these patients can be treated with intravenous thrombolysis. Very debatable point. You will encounter some anecdotal case reports. I suggest caution, particularly in the context of microbleeds. Remember that the strokes are typically small vessel disease, so you are not going to have to think often on mechanical endovascular interventions because this is a small vessel angiopathy. That doesn't mean that all patients with ischemic strokes have small vessel strokes. They may also have large vessel, but that will be less common. A common question is asked about management of migraine in these patients. This is an interesting topic. Certainly, there is the possibility that some agents like the calcitonin gene-related monoclonal antibodies may have some potential adverse effects, not so the GPANs. The use of triptans and ergot derivatives generally is not recommended, although this can be controversial. On the other hand, medications like simple analgesics, topiramate, valproic acid, lamotrigine have been used. There have been studies with borderline results with the use of cholinesterase inhibitors to improve cognition. Some people use SSRIs or SNRIs for depression or other mood abnormalities. Obviously, counseling, emotional support, physical therapy, occupational therapy, rehabilitation, exercise, and a heart healthy lifestyle are absolutely critical. There is interest in looking at the issue of nitric oxide donors. As you all know, the nitric oxide has important physiological beneficial actions in patients with stroke. On the one hand, can lower blood pressure, and it may promote reperfusion and cytoprotection. So people have investigated, and others continue to investigate, the potential value of nitric oxide donors. like, for example, L-arginine or glycerol trinitrate or amlodipine, etc. Because, for example, there are studies that showed improved endothelial dysfunction. A common question is asked when a patient with CADASIL may require a surgical intervention, and you will be consulted by the anesthesiologist in regards to any precautions or management suggestions. And these are suggestions because there is a paucity of information. Certainly, one would do everything to avoid vasospastic events. One should avoid the discontinuation of aspirin pre-op. By and large, most surgical interventions can be done while on aspirin, cardiac bypass, endarterectomy, etc. Measure electrolytes preoperative, particularly if the patient is getting acetazolamide. Maintain normovolemia, maintain adequate mean arterial blood pressure within the range of cerebral autoregulation, maintain normocapnia, maintain normonatremia, avoid head down position. Remember that volatile anesthetics may decrease cerebral metabolism and increase cerebral blood flow. On the other hand, peripheral nerve blocks are not a problem, and there are theoretical advantages of neuroaxial anesthesia over general anesthesia. So I want to, before I will summarize critical aspects of the CADASIL Consortium, let you go with 10 take-home messages. Number one, CADASIL is the most frequent cause of single-gene hereditary ischemic small vessel disease of the brain in adults. Is the most common hereditary subcortical vascular dementia. Molecular genetic testing of Notch3 gene on the chromosome 19, or alternatively skin biopsy with immunostaining are the typical steps in diagnosis. The earliest clinical manifestation, particularly in women, is migraines with aura. In men, typically are subcortical ischemic strokes. Avoid catheter cerebral angiography for a number of reasons. Number one, by and large, is not useful. These are small vessel processes. And number two, it may trigger CADASIL coma, that is a diffuse encephalopathy, oftentimes misdiagnosed as an encephalitis. Avoid anticoagulants, whether vitamin K antagonists or direct oral anticoagulants. For migraines, consider analgesics. You can use non-steroidals. You can use acetazolamide, valproic, topiramate, lamotrigine. Avoid triptans. Keep in mind the controversy with the calcitonin gene-related monoclonal antibodies. The GPANs are okay. Donepezil, some people recommend it, not proven. Obviously, physical therapy, occupational therapy, speech therapy, active cardiovascular exercise, healthy diet, emotional support to family and caregivers are critical. I would say that one of the critical points to remember is the importance of blood pressure control. I would say very, very critical to maintain control of blood pressure. That is one of the most modifiable risk factors for both ischemic and hemorrhagic strokes. So let me tell you a little bit about the CADASIL Consortium. The CADASIL Consortium is a multi-center observational study of the natural history of CADASIL. CADASIL, as we mentioned, is often misdiagnosed as other neurological disorders, and by far, the most common misdiagnosis is multiple sclerosis. The CADASIL Consortium aims to ultimately improve the care and treatment for persons impacted by CADASIL by investigating the initial presentation and the course of CADASIL participants compared to non-carrier family controls, and also to investigate the genetic, the health and lifestyle factors that impact clinically meaningful outcomes for persons with CADASIL. And it is hoped that results from this seminal investigation may also better our understanding of other types of vascular dementia. This map highlights the CADASIL Consortium study sites. There are a total of 13. These are the CADASIL Consortium investigators, the principal investigators, Jane Paulsen and Michael Geschwin, from the University of Wisconsin-Madison and the University of California, San Francisco, respectively. So get involved, follow us for updates, contact us if you have patients that want to be participants in the CADASIL Consortium. I thank you very much for your kind invitation. I hope that you did not fall asleep. If you did, I would not consider that pathological sleep, but if I would have fallen asleep during my talk, for sure that is pathological. Thank you very much. Here you have the website, the phone, and the email. I'm going to leave this information. The plan of the CADASIL Consortium is to enroll 500 persons. There are 3 in-person visits, once every 18 months, and some remote visits. The in-person visits consist on various history details, functional and quality of life assessments, neurological examination, cognitive testing, blood drawing, and brain MRI. And I'm going to leave this slide that you are welcome to copy if you wish. Thank you very much.
Thank you, Dr. Biller. There are, as you might imagine, a number of questions. And so I'm going to pass some of them on to you here. The estimate of 2 to 5 per 100,000 people seems low. The latest finding from publishing from December, I believe, show a prevalence believed to be somewhere between 1 and 450 to 500 patients with genetic mutation. If this is accurate, then CADASIL is much more common than previously thought.
You are talking about correct? The prevalence. You are the distinction between incidence and prevalence. But you may be right. The condition is better known. I think that people think about CADASIL with more information, and in the past, the data that I had of 2 to 5 per 100,000 may be all. I'd be happy to review it. Thank you very much.
Another question. There have been studies on multiple sclerosis showing that the medication, and I may mispronounce this, clemestine, brand name Tavist, may stimulate myelin repair. Have you heard of this? And do you think this could help CADASIL patients?
I don't know the answer. Certainly, when we talk about demyelination, well, there are 2 types of myelin processes, basically speaking. Those that affect well-formed myelin, demyelinating, and those that the myelin is not formed properly, demyelinating, like the leukodystrophies. Not all demyelinations are immune or inflammatory mediated, like MS. In the case of CADASIL, this is ischemic demyelination. I don't know the answer. I think that certainly would be intriguing to study that hypothesis.
Another question comes from someone with CADASIL who suffers from migraines and asks, why are ergots controversial?
Well, you want in general, in the same way that in patients who have a cardiovascular disease, you want to avoid medications that can be vasoconstrictive, vasospastic, that can aggravate myocardial ischemia or cerebral ischemia.
Okay. Is encephalomalacia common in CADASIL patients?
Encephalomalacia, I think that is a general term. Is that right? It's a general term. On the one hand, on an extreme of age, let's say in the premature, you have a characteristic condition known as periventricular leukomalacia. After a stroke, you may have in the area of infarction what is known an area of encephalomalacia. So is it what the French would call ramollissement? Is a general term. I don't know exactly what is the question, encephalomalacia, CADASIL. Patients with CADASIL have an increased risk of subcortical ischemic strokes that may become multiple, obviously, that may lead to a number of cognitive decline, vascular cognitive impairment, or full-blown vascular dementia with atrophy of hippocampal and parahippocampal structures. The pattern of involvement is different than you see in Alzheimer's disease. And remember that the type of cognitive decline in patients with CADASIL tends to affect primarily executive functions.
There's a couple questions actually about the interaction between CADASIL and diabetes. Here's one. My father, grandfather, and brother all had CADASIL and had diabetes, but nothing is ever mentioned about diabetes.
Thank you. Thank you for
has diabetes, going on, has diabetes ever been studied on the risk of stroke with CADASIL?
A good point, and I'm glad that you reminded me that I missed the very basic information. Like in any other patient who has vascular disease, you want to control the traditional vascular risk factors: hypertension, hypercholesterolemia, diabetes mellitus, heart failure, some lifestyle behaviors, particularly smoking, and obviously any other cardiac issues that may be playing a role, like cardiac arrhythmias, like atrial fibrillation. Diabetes, as you know, is an independent risk factor for stroke, for ischemic stroke. The complications of diabetes, simplistically speaking, can be categorized into macro and microvascular. The macrovascular affecting the coronary, the cerebral vessels, or the peripheral arterial vessels, and the microvascular, the peripheral nerves, the retina, and the kidney. Typically speaking, diabetes control has an impact on the microvascular complications, not so much, I'm talking about hemoglobin A1C, not so much for the macrovascular, but regardless, in patients with diabetes, we will recommend blood pressure control less than 130 systolic, less than 80 diastolic, hemoglobin A1C less than 7 or less than 6.5, and LDL of less than 70, all of these things that we will do, generally speaking, in patients with cerebrovascular disease.
There's a question about the study from California. Is UCLA up and running? How about UCSF?
They are both up and running as far as I know. I don't know if Janet wants to say a word or Dr. Gershwin. I know that University of California, San Francisco for sure is running. So everybody is actively involved, but I'll be happy to let the principal investigators, if they are attending the conference, to say a few words. I cannot identify the attendance if Dr. Paulsen or Dr. Gershwin or any other colleagues from UCLA or UCSF want to say a word.
I know UCSF is up and running. I don't know yet about UCLA. There's just a lot of questions, and we won't get to all of them. But here's one that's, I think, straightforward about the genetics. Is a mutation on Notch 3 the same within a family? Would a CADASIL blood test show this, basically?
Yeah, I think that that would be my thinking. Again, most of these mutations typically result in a gain or loss of a cysteine residue. That is the most common phenomenon. A few months ago, I would have had this slide set describing more than 170 Notch 3 variants. Nowadays, we know that there are more than 200 Notch 3 variants, but most of them seem to cluster in exons 4, 3, 5, 6, 11, and others like 2 and 18 are less common.
Here's one. Would you recommend Agrinox over baby aspirin? A neurologist recommended Agrinox for vasodilatation. I was on Agrinox for years, had many headaches on baby aspirin, but fewer on Agrinox. So kind of anecdotal story there, but
yeah, no. The answer is, first of all, in the early study of the Agrinox, many patients discontinue the medication because of headaches due to the dipyridamole, extended release dipyridamole. I think that nowadays, as in the case of ticlopidine, the most commonly prescribed antiplatelet agents are aspirin, clopidogrel, and ticagrelor. I don't think that many patients are on Agrinox or ticlopidine or cilostazol, at least in the United States. In other countries like Japan, China, cilostazol, Korea is commonly used.
okay. There's a question about eye involvement. A little complicated. Well, every brain MRI show microbleeds. Also, how does it affect our eyes? I suffer from Sjogren's syndrome and vasculitis in my eyes. Will there be research on this?
As you know, as I mentioned, that there are retinal abnormalities described, but not vaso-occlusive retinal diseases like branch retinal artery occlusion or central retinal artery occlusion or ischemic optic neuropathy or central retinal vein or branch retinal vein occlusion. It's important because in the differential diagnosis with Susac syndrome, you know that in Susac, you have branch retinal artery occlusions observed in fluorescein angiography, characteristic lesions in the corpus callosum, and also a sensory neural hearing loss. But these retinal abnormalities are different. In the case of Sjogren sometimes may be confused with multiple sclerosis, and obviously in patients with Sjogren, you have dry eyes, you have xerophthalmia, xerostomia, you have typically a variety of central or peripheral nervous system manifestations. I don't think that, I mean, it could be part of the differential because it can cause some white matter disease, but the eye manifestations will be different.
Scrolling down here through all these questions, there's an answer from Dr. Jane Paulson that all
Yeah.
sites are now up and running with the consortium. So
Very good.
that answers those questions. Yeah, that's great. There was another. Somebody is asking about, for migraine, a medication called Emgality, E-M-G-A-L-I-T-Y. Is this acceptable for use in CADASIL patients with migraine?
You are going to read that in patients with migraine, the use of the calcitonin gene-related peptide receptors, monoclonal antibodies, may be used for the prevention of migraines. And on the other hand, there are theoretical concerns about the use of these agents, not so for the GPANs. So again, relatively little experience, but some have used it, others raise concerns. You have a number of other agents, as I mentioned, that you can use: topiramate, Diamox, valproate, lamotrigine, etc. Beta blockers have not been shown to be as effective in prophylaxis. So I would stay away from beta blockers. Another agent that you can use are calcium channel blockers like verapamil, for example.
Maybe one more follow-on question here about L-arginine, and that is what formulation or what are there clinical data about L-arginine being something that might be effective?
There are, again, it's more controversial. The official position should be there is no proof that nitric oxide donors are effective. On the other hand, there is increasing interest in, for example, the use of glyceryl trinitrate as a nitric oxide donor in patients with stroke. And there are some studies in England in that regard.
Well, this has been great, and we could go on into the night. I think people have a lot of good questions. I want to say that some of the very specific questions that didn't get asked and answered, we will respond to them. We'll send you an email with answering things the best we can among those who had questions that we didn't get to. I am going to go back to one.
I am available up until midnight. Just kidding.
I'm trying to get my share screen here. And without much success. I don't suppose you can see my last slide. For whatever reason, I can't.
Yeah, we can see it.
Well, you can. Okay, great. So I couldn't see it. So I want to thank her. It was an excellent talk, and this is a very important study. If you haven't already considered participating in this study, I would strongly encourage everyone for doing so. It is, I must say, also an important step along the path to doing clinical trials. The data that we will learn from this study will be invaluable when we get to having specific therapies, I think, for CADASIL and helping to understand how to design correctly the clinical trials. And the other thing I'll say in closing, that there is going to be a recording, and it will be out, I think, in a couple of days or so, and you'll be able to access it if you want to listen to this, or if you want your friends or whatever to listen to it also. You'll be able to access the recording through our cureCADASIL website. And so unless there are any other things that I missed, again, I want to thank all the audience. It's been, I think, a great webinar, and especially thank Dr. Biller for taking the time and putting everything together in such a cogent manner. So thank you, and stay tuned. There will be more webinars coming your way.
Thank you very much for the invitation. Good night.
Good night.